Welcome to the Rad-On Smart Review Head and Neck Cancer series.
It's great to have you with us. If you've been following along, we've laid down the foundational scaffolding. We've talked anatomy, staging, fractionation.
And now we're getting to the real engine, the component that takes cure rates from pretty good to, excellent.
Systemic therapy with radiation therapy, this is it.
Exactly. Our goal today is to really get into the weeds, to arm you with the kind of detailed knowledge you need to go beyond just saying chemo helps.
Right. We want you to understand who gets it, which regimen is the gold standard, and maybe most importantly, why some of these alternatives, like Cetuximab, aren't just a simple substitute for toxicity.
Especially in HPV-positive disease. That's a huge trap.
It is. This is really where the rubber meets the road, where you're balancing that drive for maximum tumor kill with the need to keep the patient safe. It's that borderline patient that really tests your clinical judgment.
So let's jump right in with a case that puts us exactly on that tightrope. It's the perfect anchor for this whole discussion.
Let's do it.
Okay, we have a 58-year-old male, and right off the bat, he's got a 40-pack-year smoking history.
So that immediately flags him. Higher risk for recurrence, higher risk for comorbidities. A classic profile.
Absolutely. His diagnosis is a T3N2BP16 negative squamous cell carcinoma of the left tonsil.
P16 negative. So we're already in the higher risk bucket where systemic therapy is, well, it's not optional, it's mandatory if we want to maximize the chance of a cure.
Right, and the specifics on size. The primary is 3.5 centimeters, and it's just starting to extend to the soft palate.
Okay.
And the nodes, he's got multiple ipsilateral level 2 nodes, with the biggest one measuring 4 centimeters.
So that confirms his bulky N2B status, T3 N2B M0. Got it. Now, what about the patient himself, the metrics that really matter for this discussion?
He's ECOG1, so he's fit. He's up and around, certainly fit enough for an intensive treatment course.
Good. But there's a catch, I'm guessing.
There is. His baseline creatinine is 1.4. We calculate that out. And his GFR is 52.
Oof, 52. That's borderline, to say the least.
Exactly. And to top it off, he mentioned some mild high-frequency hearing loss. He thinks it's from years of construction work.
Okay, so there it is. The question lands on your desk. Which drug are you going to write for his concurrent chemoradiation?
And this is what we call the resident trap. It's so easy to fall into one of two reflexive and wrong answers.
It is. The scenario is designed to see if you can synthesize all that information, not just recite a textbook.
So trap number one is the reflex to just say high-dose cisplatin, because, it's the champion. But that completely ignores the GFR of 52 and the hearing loss. That's clinically dangerous.
And trap number two is just as bad. It's reflexively jumping to Cetuximab, thinking of it as a toxicity discount.
Right, like it's a free pass.
Yeah.
But choosing it without a true contraindication to platinum actually compromises his outcome. We know that.
So we need a structured, defensible plan. Walk me through what that sounds like, the kind of answer you'd give on your oral boards.
You want to you see the whole picture, the standard care, the patient-specific risks, and the plan to mitigate those risks.
Exactly. So let's hear that canned script.
Okay, here it is.
This 58-year-old male presents with a locally advanced P16 negative oropharyngeal squamous cell carcinoma, stage T3 N2BM0. The definitive treatment for this stage, aiming for organ preservation, is concurrent chemoradiation. The established reference standard for systemic therapy is high-dose cisplatin, administered at 100 milligrams per meter squared every 3 weeks, combined with 70 gray and 35 fractions. However, I note two significant concerns regarding this patient's eligibility for high-dose cisplatin: a borderline calculated GFR of 52 and a history of mild high-frequency hearing loss. These factors raise the risk of severe nephrotoxicity and irreversible autotoxicity. Therefore, my immediate plan is to confirm renal function with a measured creatinine clearance and obtain a formal baseline audiogram. If the measured clearance confirms a GFR below 60, or if the audiogram shows significant baseline loss, I would pivot to weekly cisplatin at 40 milligrams per meter squared with strict monitoring. If the patient is found to be truly platinum ineligible, for instance, if the GFR falls below 50, I would proceed with a non-cisplatin regimen, such as carboplatin plus 5-FU, rather than radiation alone. Cetuximab remains an option only if platin is entirely contraindicated but is not considered equivalent to cisplatin in efficacy.
That is just a beautiful answer, because you start with the gold standard, you establish that you know it, but then immediately you pivot to the patient in front of you.
You're not just picking a drug, you're outlining a safety plan. You're showing your work.
Exactly. That GFR of 52 is the flashing yellow light. You have to stop and investigate before you proceed.
You have to, because the consequence isn't just a delay. It could be acute kidney injury or permanent deafness.
Okay, so we've set the stage with that dilemma. Let's take a step back and really anchor ourselves on the why. Why are we even willing to risk these toxicities? What makes concurrent chemotherapy so critical?
The whole premise, the core reason, is radiosensitization. Adding the chemo at the same time as the radiation makes the radiation more effective.
And that improved local effect, killing more cancer cells in the head and neck.
Translates directly into better overall survival. That's the key. It's not just about shrinking the tumor, it's about eradicating it. And that improved locoregional control is what saves lives.
Let's get into the mechanism just a bit. How does a drug like cisplatin actually make radiation work better? It's not just adding one poison to another.
No, it's synergistic. Cisplatin is a powerful DNA crosslinker. So when you give it with radiation, it does two main things. First, it can kill cells that might be in a more radioresistant part of the cell cycle.
Okay.
But maybe more importantly, it prevents the cancer cell from fixing the damage the radiation just caused. Radiation creates DNA breaks, and cisplatin essentially ties the cell's hands so it can't repair those breaks before the next dose of radiation arrives.
So you get this compounding, synergistic cell kill.
Exactly.
Yeah.
And that synergy is why the timing is so incredibly important.
Right. So if you're in an exam and you're asked about induction versus concurrent versus adjuvant chemo, what's the definitive answer for where the survival benefit lies?
It's overwhelmingly with concurrent therapy. The data on this is crystal clear from huge meta-analyses like the MACH-NC analysis. They looked at tons of trials and found a consistent, durable overall survival benefit, around 8% absolute improvement at 5 years, but only when the chemotherapy was given concurrently.
And there are a couple of cornerstone trials that really cemented this, right? The ones everyone needs to know.
Absolutely. The two big ones for most mucosal sites are RTOG 9501 and EORTC 22931.
Let's start with 9501.
That trial looked at patients with advanced oropharynx, hypopharynx, larynx cancers. It was a simple question: radiation alone versus radiation plus concurrent high-dose cisplatin.
And the result?
The concurrent cisplatin arm won better locoregional control and, crucially, better overall survival. It basically set the standard of care.
And the EORTC trial confirmed it in a slightly different context.
Yes, it did. They compared a few different radiation schedules against standard radiation with concurrent cisplatin. And again, the chemoradiation arm came out on top with the best survival. It showed that adding cisplatin was even more powerful than just intensifying the radiation schedule on its own.
So given all that, what's the default board posture on induction chemotherapy for, say, a typical advanced oropharynx cancer?
The default posture has to be firm. Induction chemotherapy is not routine. The trials that have tested it, induction then concurrent versus concurrent alone, they just don't show a consistent survival benefit.
But they do show more toxicity.
A lot more toxicity. So you have to be clear. The strongest, most reproducible survival signal comes from concurrent therapy.
But there are always exceptions. What are the two big ones you have to mention?
You have to know the exceptions. Number one is nasopharynx cancer. The biology there is different. The risk of distant mets is higher. And for that site, induction followed by concurrent chemo-RT is often the global standard.
Okay, nasopharynx is one. What's the other?
The other is in certain larynx preservation protocols. But that's a specific scenario. For the vast majority of patients you see, like our case, concurrent is the standard.
And just to close the loop on the RT part of this, all this evidence is built on a foundation of 70 gray in 35 fractions over 7 weeks.
That's the bedrock, 70 in 35.
All right, so let's move from the why to the what. Cisplatin is the heavyweight champion. We've established that.
It's the reference standard for a reason. It has the strongest evidence base from those big phase 3 trials.
And there are really two main ways we give it, two schedules. Let's start with the one that was used in those landmark trials.
That would be Schedule 1, high-dose cisplatin.
What's the dose?
100 milligrams per meter squared. And it's given every 3 weeks.
So over a 7-week course of radiation, when do those doses typically fall?
You're aiming for 3 cycles. So that usually means day 1, day 22, and then day 43 of the radiation course.
Now, why is the number of cycles so important? Is there a minimum target we're shooting for?
Yes, this is a critical point. The goal is to get a cumulative dose of at least 200 milligrams per meter squared.
Too hungry.
That's the dose threshold that's really associated with the best outcomes. So for your boards, the key phrase is something like, the goal is 3 cycles if tolerated, but a minimum of 2 cycles is essential for maximum efficacy.
And we know that third cycle can be tough to get in.
It's very tough. By week 6, the patient is dealing with severe mucositis, fatigue, but you have to fight to get that minimum of 200 in.
Okay, that's high dose. Now let's talk about the other major player, Schedule 2. Weekly cisplatin.
Right. This is what you see very commonly in practice, especially for patients who are a bit more borderline.
And the dose for weekly is?
It's typically 30 to 40 milligrams per meter squared, given once a week. Most places have settled on 40 as the standard weekly dose.
So here's the million-dollar question for a clinician. High dose versus weekly. Is weekly just as good? Are they interchangeable?
This is where you need to be nuanced. The correct board stance is that high dose remains the historical reference standard. It's what set the bar in those big trials. But weekly cisplatin is incredibly widely used, and it's a very reasonable and often clinically superior alternative, especially for patients like our case. You use it when the aggressive hydration and monitoring for high dose just isn't safe or practical.
The mistake is to say they're identical in efficacy.
Exactly. Avoid saying they're identical. While a lot of retrospective data suggests the outcomes are pretty similar, you have to acknowledge the high-dose schedule has the level 1 evidence. So you'd say weekly is an accepted and reasonable alternative.
I sometimes think of high dose as a high-stakes sprint. It's incredibly intense, requires perfect preparation with hydration and labs.
And weekly is more like a marathon, lower intensity each week, but you have to manage cumulative toxicities like fatigue and myelosuppression over the full 7 weeks.
You have to match the race to the runner.
That's a perfect analogy. And honestly, many centers have functionally made weekly their default standard because it's often better tolerated and you're more likely to complete the full planned course of therapy.
Okay, so this high-stakes approach with cisplatin means we have to have a deep respect for its side effects. Let's really connect the toxicities to the decision-making. It's not enough to list them. We need to know the thresholds.
Absolutely. Let's start with the one that causes the most anxiety for everyone involved, renal toxicity.
This is the big one. It can cause acute kidney injury, but also a chronic decline that doesn't recover.
And the mechanism there is direct damage to the renal tubules. The platinum is toxic to them. That's why the hydration is so critical.
You're literally just trying to flush it out as fast as possible.
You're diluting it and increasing the flow rate to minimize contact time with the tubules. If you skimp on the hydration for a high-dose cycle, you're just asking for trouble.
Okay, next on the list is ototoxicity, hearing loss.
This one is so important for long-term quality of life. It's a high-frequency hearing loss, and the scary part is that it's often permanent.
And for our case patient, the construction worker with pre-existing hearing loss, this is a massive issue.
It's an additive risk. We absolutely must get a baseline audiogram to know where he's starting from. It's non-negotiable.
Then there's neuropathy.
Another cumulative one. It can cause or really worsen peripheral neuropathy. For a diabetic patient, for instance, this can be absolutely debilitating.
And the one that hits everyone right away.
The GI distress. Cisplatin is highly immunogenic. You cannot give this drug without a robust prophylactic triple antiemetic regimen, a 5-HT3 antagonist, an NK1 antagonist, and a steroid. It's mandatory.
Plus the myelosuppression, which can creep up, especially on the weekly schedule.
Right. You're watching those counts every single week.
So let's tie these to hard numbers. When do you officially declare a patient cisplatin ineligible? What's the line in the sand?
For renal function, the line is pretty clear. The renal hard stop is a creatinine clearance below 50 milliliters per minute.
Below 50.
Yes. The 50 to 60 range is a major caution zone where you'd probably only consider weekly with very tight monitoring. But below 50, cisplatin is off the table. The risk of permanent renal failure is just too high.
What about for hearing?
It's a bit softer, but generally baseline clinically significant hearing loss. Grade 2 or worse. Or if their job depends on their hearing, it becomes a major deterrent.
And a neuropathy red flag?
Pre-existing grade 2 or worse neuropathy. Pushing more platinum on top of that is just going to lead to severe functional impairment.
And then there's just overall fitness.
Right. ECOG2 or worse, or if a patient is just clearly frail, That's a contraindication, and you have to assess their hydration capacity. A patient with severe heart failure can't handle the liters of saline we need for high dose.
So bringing it back to our anchor case, GFR of 52, mild hearing loss, he's right in that gray zone.
He is the definition of the gray zone. 52 isn't a hard no, but it is a hard pause and confirm. You need that measured creatinine clearance. And if it comes back at 52, you're immediately pivoting to weekly cisplatin. The high-dose regimen is just too risky.
Okay, so if cisplatin is off the table, the next drug that always comes to mind is cetuximab. And this is where so many people get tripped up on their vorts.
Oh, it's a huge trap, especially with the rise of HPV-positive disease and all the talk about de-escalation.
Let's start with where cetuximab came from. How did it get its approval?
It came from the Bonner trial, or ERBITIX1. And what that trial showed was that cetuximab plus radiation was better than radiation alone. So it proved it was better than nothing.
Better than nothing. That's the key phrase.
It is. It earned its license as an option for patients who truly could not get platinum.
But the critical point, the thing that has changed in the last decade, is that it is absolutely not a cisplatin equivalent, especially not in HPV-positive patients.
This is the single most important takeaway for this topic. We have two massive practice-changing trials that tested this head-to-head. RTOG 1016 and the de-escalate trial.
Both looked at HPV-positive oropharynx cancer and randomized patients to either the standard cisplatin RT or the experimental arm, Cetuximab RT.
And the results were completely unambiguous.
They were not subtle.
Not at all. Both trials showed that cetuximab was significantly inferior. Patients who got cisplatin had better disease control and better overall survival. The RTOG trial was even stopped early because the inferiority of the cetuximab arm was so clear.
What's the biology behind that? Why is cisplatin so much better in these tumors?
Well, even though HPV-positive tumors are more radiosensitive, they still depend on their DNA repair pathways. Cisplatin, as we said, is a potent DNA damage agent. It hits that vulnerability directly. Cetuximab blocks an EGFR pathway, which is relevant, but it just doesn't provide that same powerful synergistic hit with radiation.
So if you're aiming for a cure, you need the bigger gun.
You need the bigger gun. And that leads us to the board rule. You need to be able to state this clearly.
What is it?
The board rule is cetuximab is not de-escalation. It is a fallback option for when cisplatin is contraindicated. You never, ever offer it to a fit platinum-eligible HPV-positive patient just to reduce toxicity. That is a critical error.
And we also need to get rid of this idea that cetuximab is somehow less toxic.
It's not less toxic, it's just different toxic. You trade the kidney and hearing risk for a whole new set of problems.
It's like the rash.
A horrible acneiform rash that can be disfiguring and painful.
Yeah.
You also have a risk of infusion reactions, and you have to constantly monitor electrolytes, especially magnesium. It is not an easy drug to take.
Okay. This is a lot of information to process under pressure. We need a framework, a logic tree, to help organize this decision-making.
Yes, you need a clear hierarchy for what to do when your standard high-dose cisplatin is off the table.
So what's the first pivot? Where's the first branch in the tree?
Step one is borderline fitness. This is our case patient. He's not truly ineligible, but high dose is too risky. So you pivot from high dose to weekly cisplatin.
You stick with platinum, but you change the schedule for safety.
Exactly. That's the first and best move.
Okay, but what if he's worse off? What if his GFR was, say, 45, a true hard stop?
Now you move to step two. Truly cisplatin ineligible. You can't use cisplatin at all, so you have to pick a different concurrent regimen that still has good evidence.
And what's the classic choice there?
The classic choice is carboplatin plus 5-FU.
So another platinum agent, carboplatin. Why is that safer?
It has a different toxicity profile. It's much less nephrotoxic and ototoxic than cisplatin. It's more myelosuppressive, but it's manageable. And the evidence for using it with 5-FU comes from older larynx preservation trials. It's a well-established backup regimen.
Okay, so after that, where does cetuximab finally make its appearance?
It's step three, platinum intolerant or contraindicated to both. You go to cetuximab when you can't use any platinum agent safely. Not cisplatin, not carboplatin. This is for your truly frail patients or those with just prohibitive organ damage.
And when you make that choice, you have to state the caveat.
You have to explicitly say that you know it's not equivalent, especially in HPV-positive disease, but it's the best remaining option.
What's the last resort? The end of the line.
Step four is radiation alone. If the patient is just too sick, ECOG 3 or 4, and can't tolerate any systemic therapy, then high-dose radiation is all you can offer.
And that's when the pressure falls squarely back on the radiation oncologist.
100%.
Yeah.
Because you've lost your radiosensitizer, the only lever you have left to pull is maybe altering the fractionation schedule, hyperfractionation, or an accelerated course to try and claw back some of that lost biological effect.
The big clinical pearl here is that losing cisplatin is a major blow to your chance of local control.
It's a huge blow. And it means you have to be absolutely flawless with the radiation. No treatment breaks, aggressive nutritional support, meticulous target coverage, because you don't have that systemic therapy safety net anymore.
Okay, let's get into the practical side of this. The safety protocols you absolutely must have in place. Let's start with timing.
Timing is everything for that synergistic effect. You want to start the systemic therapy on day 1 of radiation, if at all possible.
And for high-dose cisplatin, that rhythm of day 1, 22, and 43 is key.
It is. Missing those windows because of delays or toxicity really starts to undermine the whole principle of concurrent therapy.
Before you even write the order for cycle 1, what are the mandatory baseline checks?
4 things, minimum. First, a real renal function assessment, ideally a measured creatinine clearance. Second, a formal baseline audiogram.
Got it.
Third, a thorough neuropathy exam. And fourth, an honest assessment of their ability to tolerate hydration. And of course, a full dental clearance before you start anything.
Okay, treatment is underway. The patient is on weekly cisplatin. What are the triggers that make you hold a dose?
You're monitoring them weekly. If a creatinine clearance drops below your threshold, say below 50, you have to hold cisplatin and reevaluate. Same if their hearing takes a significant dive or their neuropathy gets to grade 2 or 3.
But, and this is critical, you don't hold the radiation.
You never hold the radiation. You manage the side effects. You support the patient through the mucositis with feeding tubes, with pain meds, but the radiation clock keeps ticking. A treatment break is what we call cancer feeding time. It's the worst thing you can do for local control.
Let's quickly review the specific management for the 2 big agents. For high-dose cisplatin, what's the mantra?
Hydration, hydration, and more hydration. Aggressive pre- and post-hydration with saline. You check renal labs before every single cycle, and you have to watch their electrolytes like a hawk, especially magnesium and potassium.
And for cetuximab, what do you tell the patient to expect?
You have to counsel them about the rash. Tell them it's coming, that it's a sign the drug is working, and that you have a plan to manage it with creams and sometimes antibiotics. And you watch for infusion reactions and check those electrolytes regularly.
Tying this all back to our case patient's hearing loss, the late effect anchor.
Right. Because he's already starting with a deficit, you have to be extra careful in your radiation planning. The goal is to cover your target, of course, but you're also trying to keep the dose to the cochlea as low as humanly possible.
Because the risk is additive. Radiation plus cisplatin.
It's a double hit to the ear. And having that baseline audiogram lets you quantify the risk and have a very honest conversation with the patient about what might happen.
All right, we've covered a ton of ground. Let's distill this for a board review setting. Let's hit the 3 classic exam killers.
Okay. Trap number 1, the cetuximab de-escalation fallacy.
This is when you offer it to a fit HPV-positive patient to try and lower toxicity.
And that's an immediate fail. The response is to cite RTOG 1016 and state that cisplatin is superior for oncologic outcomes.
Okay. Trap number 2.
Ignoring the safety data. This is giving cisplatin to a patient with a GFR of, say, 40.
Another clear fail.
It shows unsafe practice. You have to recognize the hard stop and pivot to a safer alternative like carboplatin.
And trap number 3.
This one is more subtle. It's prescribing high-dose cisplatin without mentioning the supportive care.
Forgetting to mention the hydration, the antiemetics, the lab monitoring.
Exactly. It shows you know the drug name, but you don't know how to safely give the drug. The whole package matters.
All right, let's do a rapid recall drill. I'll ask, you answer. Core sequencing for survival benefit.
Concurrent systemic therapy with RT.
Reference standard cisplatin schedule.
100 milligrams per meter squared every 3 weeks, 2 to 3 cycles.
Minimum cumulative cisplatin target.
About 200 milligrams per meter squared.
2 big contraindications for cisplatin.
Poor renal function creatinine clearance below 50 and significant baseline hearing loss or neuropathy.
And when is cetuximab appropriate?
When platinum is truly contraindicated, with the mandatory caveat that it's inferior in HPV-positive disease.
Perfect. Let's run a quick board blitz. Multiple choice. Question 1. A healthy 40-year-old HPV-positive patient asks for cetuximab to reduce toxicity. Best response. C. Cetuximab is inferior for control and survival compared with cisplatin in this setting.
C is the only correct answer. You have to counsel them based on the level 1 evidence.
Question 2. A 74-year-old hypopharynx patient has a GFR of 45. Best concurrent option. I'm going with C again, carboplatin plus 5 FU concurrent therapy.
Correct. The GFR of 45 is a hard stop for cisplatin, so you pivot to the established non-cisplatin backup.
Last one. Question 3. Which statement is most correct regarding timing of systemic therapy? B. Concurrent systemic therapy is the timing most consistently associated with survival benefit in broad populations.
B is correct. That's the core message from all the major trials.
Okay, we've broken down a very complex topic. Let's wrap it up with the 3 key clinical pearls to take away.
Sounds good.
Clinical Pearl 1. Concurrent systemic therapy is the standard for most locally advanced cases because that radiosensitization provides a direct survival benefit.
You have to fight to keep it in the plan if the patient is eligible. It makes that much of a difference.
Clinical Pearl 2. High-dose cisplatin is the reference standard, but weekly cisplatin is a very common and very reasonable compromise for safety and tolerability.
Completing a full course of weekly is better than starting high dose and having to stop after 1 cycle because of toxicity.
And Clinical Pearl 3. Cetuximab is a fallback, not a de-escalation tool, and you must know that it's inferior to cisplatin in HPV-positive oropharynx cancer.
That's the modern reality. So in summary, cisplatin is king when it's safe, weekly is your go-to compromise, carboplatin is the backup, and cetuximab is the option of last resort. And if you lose systemic therapy entirely, it's all on the RT to be perfect.
A great summary. Which brings us to a final thought to leave you with. We mentioned briefly that induction chemo isn't standard for most oropharynx cancers. But there is a specific disease site where induction is the standard. So the question is, what site is that? And why is the logic for using induction there completely different than it is for typical tonsil cancer? Think about the risk of distant disease.
An excellent question to ponder, and it's a perfect lead-in to our next session, where we'll cover the art of supportive care, PEG tubes, pain control, nutrition, all the practical things you need to do to get your patient across the finish line.
Find comprehensive tutoring materials and complete practice oral boards at radoncsmartlearn.com. Thank you for tuning in to the Radonc Smart Review Head and Neck Cancer series.